Okay, thank you so much, everybody. And that's quite a hard act to follow, Dr. Creedon. So I hope I can kind of do this justice. It's an absolute privilege to be asked to speak today at your conference. Thank you very much. And also, I absolutely love the theme, Wither or Evolve. I think it's fantastic. It really got me thinking. And I really hope that by the end of this, we will see that nursing is most certainly evolving. So what I'd like to do is to give you a bit of an overview of advanced nursing practice in the UK, and then to sort of home in a bit more on ANPs in supportive and palliative care. I'd then like to give an overview of non-medical prescribing in the UK, and then also to focus in a bit on non-medical prescribers within supportive and palliative care. I'm going to look at some of the literature and some of the history, but quite a lot of this is going to be some of my own sort of thoughts and experiences. So I hope that's okay with you all. So a bit of background. So essentially, ANP roles have emerged over the last sort of 30 years, and this has been in response to increasing complexity of health needs. And I think Dr. Creedon talked really beautifully about that as well. I think we know, don't we, that people are living with a lot more chronic conditions now. I think we're seeing people live longer, and certainly cancer treatment's getting better, which is great. But actually, I think that there's just an increasing complexity that we're seeing, and certainly increasing complexity in symptom management. But the roles have also emerged with sort of this reduction in the medical workforce. And I think in some ways this is a really great thing, because it means that actually the unique skill that nurses can bring to healthcare is being recognised. I think the slightly negative side of this is sometimes ANP roles are very much more about just sort of doing more tasks and getting skilled in more tasks, rather than maybe an actual way of working. Certainly our NHS long-term plan, published in 2019, highlights how advanced nursing practice is really central to helping transform service delivery. And again, just focusing a bit on Dr. Creedon's talk, I think there's a lot of transforming that we need to do, and certainly with linking with the acute and community sector. So if people sort of say to you, well, what is an advanced nurse practitioner? This is an international definition that I quite liked. It's quite old, I'm afraid. It's from 2009, but it basically says it's a nurse who's prepared beyond the level of a nurse generalist and authorised to practice with advanced expertise in a nursing field. Specialist practice includes clinical, teaching, administration, research, and consultant roles. I think this is really interesting, and I think actually the word authorised jumps out to me there, and I'm going to talk a little bit later about in the UK how I think we feel we've got a bit of work to do in actually sort of regulating some advanced nursing practice. So this is from the Royal College of Nursing, and these are the standards that they've set out for advanced nursing practice, and actually advanced level nursing practice. So they actually say that advanced level practice it's a level rather than a type of practice. So it's not a specific role, but actually it covers many different roles. And I think we see advanced nursing practice within supportive and palliative care, but also within the community sector, within mental health, within the hospices. So I think it's very much about a level of practice rather than a type of practice. It's also applicable across various different settings, as I've just mentioned. And again, I think it's really key in actually linking care across different settings as well, and maybe coordinating care a little better. The RCN and also Health Education England also highlight that ANPs should ideally be educated to master's level. So for us in the UK, that's a level 7, but we should also be showing evidence of practice within 4 pillars, and that's clinical, management and leadership, research and education. And I'm going to come on a little bit later to talk about kind of those different pillars and how important they all are to contribute to the role of an advanced nurse practitioner. Now, something I think that we possibly haven't got quite right in the UK, and I think something that can be a little bit confusing, is that there are many different titles that probably come under the umbrella of advanced nursing practice. So we have clinical nurse specialists, and these can be nurses maybe working with specific groups of cancer patients, or perhaps in diabetes. We have an inflammatory bowel disease nurse specialist. So the clinical nurse specialists, or all CNSs, are quite a common role in the UK. We also have advanced nurse practitioner, or ANP. They will commonly maybe be seen in the emergency department or in GP practices. Also advanced clinical practitioner, these roles are becoming more common now, and we have some of these in oncology care as well, and also nurse consultants. And I think there is a lot of crossover with all of these roles. And I think actually everybody, if you try to explain what is different about all of these roles, I think we all find it quite difficult. There's been some literature, some papers written that try to distinguish between all the different roles. I think what's very clear is that there is an awful lot of crossover, but essentially it's about working at that advanced level. I think nurse consultants are very interesting and I think really, really key roles. And I'd really like to see these growing more in the UK because nurse consultants have been around for a long time. And the whole ethos behind a nurse consultant is this is about nurses with a lot of experience and a wealth of knowledge actually staying in clinical practice. And I sometimes think with nursing, certainly in the UK, perhaps we've got it a little bit wrong, where certainly very senior nurses and nurses with loads of experience often move into management roles and maybe move away from clinical practice. But I think junior nurses and patients really do benefit from that experience, much like in the medical profession. So in the UK, there's actually no formal regulation for these roles. So of course, all of our nursing practice is regulated by the NMC, but where advanced nursing practice roles are concerned, there's actually no formal regulation. This was kind of recognised by Health Education England back in 2017, and they wrote this framework for advanced clinical practice in England. And I think this is a really, really nice framework because it's not just about nursing, it's a multi-professional framework. And I think it's about us all kind of working together and recognising this level of practice. So it's essentially developed with the aim of consistency nationally, and I think also sort of in response to there not being a formal regulation for advanced nursing practice roles. It's designed also to provide clarity for employers, which I think is really important. I think it's not so much about sort of writing the job description or creating the role. It's about having a framework that underpins these roles. It's also for other healthcare professionals, but I think also for ANPs themselves to have something to actually sort of map their practice against. It provides a structure for organisations to monitor their ANP workforce, which I think is really different. It's a growing workforce. All the roles look really quite different. So I think it's really good to have this structure in place now. Also, academic institutions who now have post-graduation courses, so master's courses, they are actually now accredited according to this framework. So all the courses have to kind of follow a very similar framework. And you can actually search up educational institutions to clarify whether their courses are accredited with this framework. There's also the Centre for Advanced Nursing Practice, which is supported by Health Education England, which is also a fantastic resource for ANPs, or also for organisations who are developing ANP roles. Again, some of the other challenges, as well as regulation, I think, and this is written about quite extensively in the literature. These are two really good papers. And I think one of the problems is that many roles only really allow time for the clinical practice pillar. And I think, again, listening to the previous speaker talking about how busy everybody is now and how actually, even if we've got the funds there, it's really, really different to recruit. And I think we can all, and probably quite rightly, actually, our clinical practice and our patient time has got to be the priority. But I think sometimes we can be a little bit short-sighted, and it's why it's fantastic having conferences like today and knowing that there's so many attendees, because actually we do need to be thinking about our continuing professional development, our education, and actually keeping up to date with things. And that does actually have ultimately a positive impact on patients and the care that we're providing. I think there's a lack of supervision and mentoring. It's not readily available. And I know within our trust, we've tried many different sort of models of providing supervision for advanced nurse practitioners. And I think sadly gone are the days where we can all have one-to-one supervision and mentoring, because there just aren't the people there to be able to provide this. But I think we do really need to be thinking about how ANPs are supervised and mentors. I know within our team, just generally sort of supervision and mentoring amongst ourselves is what we found most beneficial. So a little bit of a personal perspective, and I'm just going to talk a little bit about our team now, a group of advanced nurse practitioners, and kind of how we work and how we work within the 4 pillars. So this is our hospital in Guildford in Surrey. It's a district general hospital, but it's also a tertiary cancer centre. So we have a large cancer centre attached to the district general hospital. So our team, we have 3 consultants, which make up 2.4 whole-time equivalent. We have 1 lead nurse, which is myself. We have 6 other CNSs who make up 5 whole-time equivalents. 5 out of the 7 of us are non-medical prescribers. We have 1 very experienced research nurse, and we have an occupational therapist who's due to start in May, which is great because we've never really had AHP support within our team. We're a 7-day face-to-face service, and this is something that we started 10 years ago. So every weekend there's 1 clinical nurse specialist who's in the hospital carrying out face-to-face consultations, and our consultants are on at the end of the phone out of hours if we need any advice. And we also have 4 outpatient clinics, and this is very much for our supportive care service. So we have 1 virtual clinic that I run once a week, which is telephone and video consultations, and then we have 3 face-to-face clinics that the consultants run. So if we think about the clinical practice pillar from us as clinical nurse specialists and advanced nurse practitioners, we carry out independent assessments, we formulate management plans, and we prescribe. And I think what's really lovely about this is it allows us to complete sort of a whole episode of care for patients. And I think that's really beneficial for patients. I think we're using multiple sources of information to formulate management plans, and with the complexity that we're seeing with patients who, again, are coming in from the community, and it's really important that we're understanding about the care that they've been having in the community. I think we're working with a lot of complexity, and I think we're also these days working with quite a lot of uncertainty as well for patients and for us, for ourselves. And I think we really need to be able to support patients in kind of holding and living with some of that uncertainty. I think we all work with advanced communication skills, and I think, and I'm sure all of you would recognize this, I think sometimes we don't appreciate actually how much we're using our advanced communication skills with patients and other healthcare professionals. So we complete RESPECT forms. RESPECT is recommended summary plan for emergency care and treatment, and that incorporates the DNA CPR, but it's actually much more than a DNA CPR. It is about advanced care planning and things like that. And we, as advanced nurse practitioners, are now completing competencies to be able to fully complete these forms. I think we're also advocates for changes in goals of care where appropriate. And I think very often we see people being really quite actively treated when perhaps the goals of care should be changing to more of a focus on symptom control. And I think we can really be advocates through our advanced communication for those skills. As I mentioned, we have independent nurse-led supportive care clinics, and we're independently working at the weekends. And leadership. So I think this is a really, really important pillar. And again, I think it's something that should be integrated throughout all the care that we're delivering. So for myself as the lead nurse for the team, I'm continuously looking at developing the nursing team and our service. And I think this is where in the literature actually where you sort of read about advanced nursing practice, but there's a lot written about advancing nursing practice. And I think this is really important. And it also makes us realize that it's something that's ongoing. So I think very nicely links in with the whole evolve theme of your conference. I try to be very clear about ensuring clarity of roles and foster productive working. We're a team who we don't take over the care of all the patients that we see, so we're an advisory team. So I think it's really, really important that we're very aware of what our role is and what we can add to the patients care, and what's maybe for other teams to lead on. I think it's really important that we're constantly evaluating our services and we're constantly collecting data sort of through audit and in response to feedback and things like that about evaluating our service. So we're constantly trying to improve. And then again, and as Dr. Creedon spoke about, I think it's about that integration of services across boundaries. And I think this takes quite strong leadership to be able to sort of work well with services across boundaries. We're all struggling. We're all sort of overwhelmed with some of the work, but I think it's just about working well together in those situations. And then education. I think it's really important to be aware of our own learning needs and to critically reflect. And I think this is something that as an advanced nurse practitioner, we should all be doing. And I think we need to evidence our ongoing CPD. I think we need to be contributing to a culture of learning and to inspire future and existing staff. And I know within our team, we're very proactive in accepting nurses to come and spend time with us and working alongside nurses. And one of the things we found through education of staff is actually being present and being visible on the wards and working alongside staff, maybe asking nurses to come in and see patients with us. And if we're having maybe complex conversations, and it's about that role modeling. And I think that this is a really, really good way of educating, certainly in busy times. I know for me, looking back, some of the stuff that I've sort of learned the most has been from fantastic role models and working alongside them. So that's certainly sort of the ethos of our education. I'm always sort of keen to identify developmental needs of the team, and people are encouraged to sort of suggest ways that they want to develop themselves. I think as ANPs, and I think it's something we sometimes shy away from, I think we really need to seize opportunities to teach. So I think within our teams, we have a journal club where we're encouraged to present papers. We also have an ANP group at the hospital. But I think also opportunities like this to present at a formal course is really, really fantastic. And I encourage all of our nurses to do that. And also sort of speaking again at conferences, and sorry, formal courses, I meant things like sort of university courses and things like that. I teach on a module at Sheffield Hallam University, which is really fantastic and allows me to sort of engage with a lot of the other students and learn an awful lot from them as well. And then moving on to research, and this is a quote that I really like, that a professor of palliative medicine, I heard him say this when he was doing a talk, and he said, even if you don't do the research, support the research. And this really struck a chord with me, because I think, you know, being a research nurse is undoubtedly, it's a full-time job, but it doesn't mean that as ANPs we can't be supporting or engaging in the research within our practice. And again, it's things like engaging in setting up journal clubs. I think also be aware of studies taking place in your areas of practice and engage with the research team. Our research nurse has just taught me so much. She often comes and does teaching for us about studies that are underway or are being set up. So I think that's really important. And I think also engaging in supporting recruitment is really important. I mean, we're the ones that are having face-to-face interactions with patients, so I think we're in a really good position to do that. I think it's also about actively contributing to surveys and questionnaires and Delphi groups and things. I mean, often, you know, a survey pops into your email inbox or a questionnaire and you think, oh, I haven't got time to do that. But actually, you know, in that way, you're contributing to someone else's research, be it their PhD or their MSc or something like that. I think it's a really important thing for us to do. And love it or hate it, I think social media can be a force for good. There's an awful lot on, if you engage in Twitter, kind of follow the right people, there's an awful lot that you can find out about projects that are happening and ways to be involved. So I think even if you're not a research nurse, I think there are lots of ways that you can become actively involved in research. So what about evaluation of the roles? Well, I think organisations that are employing or developing ANP roles need to ensure governance is in place to monitor these. And that HEE framework that I talked about earlier provides excellent governance for us to be able to do that. I think as ANPs, we need to be able to show evidence of the elements of our role. I think it's sometimes easy to sort of sit back and think, well, I've got this post now, actually, you know, just going to get on with it. I do think we need to be showing evidence. And for us in the UK, we do that through our revalidation, which we do every 3 years. And we have to provide quite a lot of information to the NMC about what we've done in that previous 3 years. But also through our PDRs, our performance development reviews, I think it's important that we're highlighting how we're evidencing practice within those 4 pillars. And certainly with the nurses that I manage, we have a lot of discussion around this at performance development reviews. So let's move on now to non-medical prescribing. Non-medical prescribing sort of first came into the UK in 1992, but it was from a very limited formulary. It was mainly district nurses prescribing dressings. In 2006, NMPs were able to prescribe any licensed medication for any condition within their sphere of confidence, and that evolved to increase controlled drugs in 2012. And I think the UK probably is one of the sort of leads the way with NMP, because we have nurses, pharmacists, radiographers, physios, podiatrists, and optometrists who are now able to prescribe, which I think is really, really fantastic. So the training is taking place via a university, an educational institution, and they run NMP courses at level 6 or level 7. So level 6 is undergraduate, level 7 is postgraduate. It's typically a 6-month programme, and it's underpinned by the Royal Pharmaceutical Society framework. So this is the framework here, which is just due to be updated again in September this year. It's an absolutely brilliant comprehensive framework. Kind of think of it as the prescribing Bible, really. It's really, really useful, and it is what all the NMP courses are based on. We had some communication with the Nursing and Midwifery Council in 2018, just to get an idea of numbers. And they highlighted that about 6% of nurses in the UK at that time had the NMP qualification. I think that's probably grown quite significantly over the last few years. I think it's difficult, however, to accurately quantify, as unfortunately not all prescribers are using their qualification. So just because you are registered with the NMC, it doesn't necessarily mean that you're actually using that qualification in practice. So there's been some work looking at the role of the NMP, and this was a Cochrane systematic review that was carried out in 2016, and it looked at various papers kind of comparing non-medical prescribing versus medical prescribing. And actually what they found was that non-medical prescribing has shown to be as effective and as safe as usual care as medical prescribing. There have been some other studies that have actually surveyed patients when they have had their care provided by a non-medical prescriber, and they highlighted that in some situations there was better continuity of care, there was a perception of a more caring style of consultation, and actually some patients reported that their conditions were better controlled. So I think actually there's a lot of evidence behind NMP being a real force for good. Some NMPs have reported that prescribing authority increases their job satisfaction, their self-confidence, and enables better use of skills. And as I mentioned earlier, for us, I think it's really nice because we feel that we can kind of complete a whole episode of care rather than maybe doing the assessment and formulating the management plan, but having to ask someone else to maybe do the prescribing. NMPs report that the feeling the skill improves their relationships with patients, and it certainly saves time. And I really, really believe this. I think certainly for us, and certainly working in supportive and palliative care, actually timely symptom management is so key, isn't it, for our patients? And I think if you can prescribe, often it means that patients do kind of receive their changes or their modifications or their medications in a more timely way. However, there are some downsides, and there's quite strong evidence that not all NMPs actually use their qualification, which seems a real shame when you've done a 6-month course, which is actually really quite hard work, and then you don't use your qualification. And this is due to lack of confidence, lack of support, and sometimes lack of opportunity. And I think this is a real shame, and I think it shows that you can't work as an NMP just completely on your own. You really do need your organisation and your peers and your colleagues behind you. I think there is a risk, and I've seen this in our organisations, that NMPs can become a bit of a scribe. So you see some nurses maybe on ward rounds and they're purely prescribing what is kind of dictated to them. This is not always happening, but you do see it happen, and I think it's actually really important that if that is part of your role, that you're sort of prescribing what's dictated to you, that you are also engaging in independent prescribing decisions as well, because I think this is where it really does benefit patients. So what about NMPs in supportive and palliative care? Well, I think traditionally in palliative care, advanced nurse practitioners made recommendations to medical teams regarding medications for symptom control. And certainly before I was a prescriber, this is what I would do. But as I've mentioned previously, this can result in delays and it can result in interruption to treatment. And I think as palliative care ANPs or CNSs, we're so skilled in holistic assessment. I think it's something that we do really, really well. And I think coupled with that, we have really good knowledge of the medications we use for symptom control. And I think that does come back to where we've been making recommendations to medical teams. So actually all of that put together, I think it really kind of highlights that nurses in supportive and palliative care are a really, really good group to engage in non-medical prescribing. I think the other thing that we do, and we do really well, is we provide ongoing follow-up. So we're constantly reviewing our patients and reassessing, and I think that's a really important thing, again, for non-medical prescribing and to be a successful non-medical prescriber. And it's not just the actual prescribing of the drugs. I think as NMPs, we're in a really unique position to de-prescribe. And this is something I've got a bit of a personal interest in. I think it's really important. It's about reducing tablet burden, reducing duplicate medications. It's shown that de-prescribing can really improve quality of life, and it can also reduce cost. And that's never a bad thing, is it? So I think for NMPs in palliative care, again, as well as other NMPs, despite having the skills and knowledge, some do report a lack of confidence and limited use of their skill. And there was a study that was done specifically around sort of surveying non-medical prescribers in palliative care. And this was something that came out, which feels really quite disappointing, as I said, when you've worked hard to get that qualification. My feeling is it's really, really important to have a good support network from your MDT and from your organisation. And we're really fortunate in our team. Our consultants have always been behind non-medical prescribing and have really supported it. But also our organisation, our Deputy Director of Nursing is the NMP lead. She holds meetings every month, is hugely supportive. So it's just provides a really good support network. And I think actually evidence of, again, continuing professional development and reflection is key. And if you're a non-medical prescriber, when you evaluate, one of the reflections that you have to write is around your non-medical prescribing. So I'm just going to finish off showing you a little project that we did, a little sort of service evaluation that we did a few years ago. This was something that I did with a couple of my colleagues and Professor Andrew Davis, who was working with us at the time. And it was really in response to reading some of that literature around some non-medical prescribers in palliative care not using their qualification. We wanted to look a little bit more at our prescribing practice and to highlight any barriers. And we also wanted to look at the range of medications that we were prescribing. So really simple methodology. We just carried out a prospective review of all consultations over a 3-month period and our prescribing activity of 3 CNSs. That was back in 2018. We just collected data in a simple Excel spreadsheet, and we wrote this up and published it as a short report in the BMJ Supportive and Palliative Care, and I presented it as a poster at the Multinational Association of Supportive Care in Cancer conference. So essentially in that time period, we had 493 consultations with 186 individual patients, and 247 of those consultations resulted in a prescription. So in 209, a drug was started, in 23, there was a dose change, and in 15, a drug was stopped. And in 246 consultation, there was no change in prescription. And I'm really delighted to say, and we were really pleased to see that actually that's because there was no indication for change. There were just 10 cases where we gave advice to the treating team rather than actually prescribed ourselves. And in 2 situations, we kind of knew what we wanted to prescribe, but maybe did slightly lack the confidence. So we got advice from our consultants. But on the whole, we were sort of doing a lot of independent prescribing. This just shows a bit of a range of the medications that we prescribed. And again, the pie chart just shows that sort of the reasons for drugs being not prescribed. And in the vast majority, it's because there was just actually no indication. So the main thing we're prescribing is for symptom management. So analgesia and analgesia for moderate to severe pain was the most common drug that we prescribed. But we were prescribing various other things as well for different symptom management. And we were also prescribing quite frequently off-label medications. So our conclusion was that we have the autonomy and confidence to prescribe independently in a wide range of situations. We didn't have any robust outcome data, but we feel that patients benefit from this practice. We all agreed it enhanced our job satisfaction, and we didn't see any particular barriers that we identified. We acknowledge that it's supported by the whole team and the organisation as well, which is fantastic. So from us, a big thumbs up for non-medical prescribing within supportive and palliative care. So just in conclusion for my whole presentation, I think there's a real drive to continue to develop ANP roles in the UK. And I think this is a really good thing as long as there is a good sort of ethos and framework underpinning this. I think evaluation and standards for some of these roles has really improved, although I think we still have got more to do in regulating these roles most definitely. I think ANPs need to evidence the level that they're working at. I think that's a really important part of what we do. And I think we need to evidence that within the 4 pillars. And I think we do this through our PDR processes and through revalidation, CPD and reflection. I think ANP roles work really, really well in supportive and palliative care. And I think there are growing numbers of nurses and other healthcare professionals becoming non-medical prescribers, and the standardised framework has again really improved the governance surrounding this. I think NMPs work really well in supportive and palliative care and should be encouraged, but they really do need the support of the whole team and the organisation as well. So thank you very much.